Hi, my name is Nick Kuntz. I'm a neuroradiologist at Mayo Clinic, Arizona. And for this tutorial, I'm going to be talking about jugular foramen masses and how we can use their imaging appearance to really drill down the differential diagnosis and come to a very specific answer in most cases. So the whole goal here is to try to take something that may seem very complex on its surface and really simplify it. And I think we can accomplish this on imaging by looking at the CT bone characteristics and the MRI signal characteristics. So again, hopefully we'll take something challenging, something that we encounter not too infrequently in head and neck imaging, and drill it down to something pretty simple and easy for you to digest. Okay, so I have no financial disclosures. I do want to start with an index case, and this is a patient who presented with headache, tinnitus, and hoarseness. So take a look at these three images. The image on the left is an axial contrast-enhanced CT shown in bone algorithm reconstruction. The image in the middle is an axial T1 weighted image. This is a pre-contrast T1 weighted image. And then the image on the right is a coronal T1 post-contrast image with fat saturation. So again, history is headache, tinnitus, and hoarseness. What's the diagnosis here? And importantly, why do you think that's the diagnosis? I'll give you just a couple more moments to look at this. Okay, we'll circle back to this case at the end of this talk. So my objectives here, first and foremost, will be talking about just some very basic anatomy of the jugular foramen. And why is that important? Well, if you understand the anatomy and you understand what lives in the jugular foramen, what originates here, you can figure out what type of masses to expect. And really, there's not that many things that live in the jugular foramen, so therefore there's not that many masses that can occur here. We'll move the discussion into primary masses of the jugular foramen, things that actually originate in the foramen from structures that are contained within it. And then the last part of this talk, I'll talk about secondary masses of the jugular foramen, things that start on the outside of it and potentially can involve it. All right, so let's talk about the jugular foramen anatomy. So this is a skull-based structure. It's located off midline, and it's situated between the temporal bone and the occipital bone. So here's our jugular foramen. And this is contiguous to the carotid space. So if you go just below the skull base, this funnels right into the carotid space within the suprahyoid neck. So this is what our jugular foramen looks like on a non-contrast CT. This is our jugular foramen right here. And sitting in the middle of it, originating off the anterior wall, we have our jugular spine. And the jugular spine is this very sharp, tack-like structure, and that separates the jugular foramen into two distinct compartments. We have our pars nervosa, which sits along the medial portion of it, and that contains cranial nerve 9 as well as the Jacobson nerve and the inferior petrosal sinus. And then sitting lateral to that, lateral to the jugular spine, we have our pars vascularis. That contains cranial nerves 10 and 11 as well as the Arnold nerve. Importantly, the superior jugular bulb, so that's the big venous structure that we always associate with the jugular foramen, as well as contains the posterior meningeal artery. Now, is it that important for you as a radiologist to be able to differentiate, this originates from the pars nervosa or pars vascularis? Probably most of the time, no, it doesn't really matter that much, but it does help you to sort of compartmentalize things and understand these structures better. And that way you can really have a better appreciation for and a better understanding of the potential pathologies that can occur here. So let's talk about the coronal relationships of this jugular foramen anatomy. So sitting above the jugular foramen, so here's our jugular foramen, sitting above it and sitting lateral, we have our temporal bone. And then sitting inferior to it and medial to it, we have our occipital bone. So superlateral, we have our T-bone. Infralateral, we have our occipital bone. Now, as we look at some of the important anatomic structures that live off of this, one of the ones that is really critically important for you to recognize on this coronal CT image is the jugular tubercle, and that's what the arrow is denoting. Now, the jugular tubercle is important because it serves as an anatomic marker that divides the jugular foramen, which sits sort of above it and lateral to it, from the hypoglossal canal, which sort of sits below or inferior and medial to it. So superlateral, we have our jugular foramen. Infromedial, we have our hypoglossal canal. So this structure kind of looks like a bird's beak. This has been reported as kind of looking like an eagle. I think honestly it looks more like a vulture. But any way you cut it, That's an important structure so that you can help to figure out, do I have a mass that's originating from the jugular foramen, if it's centered up above it, or if it's down below it, we're thinking about a mass that's coming from the hypoglossal canal. So the type of structures that we find within the jugular foramen will certainly help to predict the different types of pathology as well as the symptoms that occur as a result of the pathology arising from the jugular foramen. So obviously, when we think of jugular foramen, we think of vasculature, and so it contains blood vessels. This is a place where we may see thrombus, typically bland thrombus, but sometimes tumor thrombus. And because it's such a vascular containing structure, we think about things like hematogenous metastatic disease that can occur here. We also have nerves that live within the jugular foramen. We've got multiple nerves, as I mentioned before, so we think about things like schwannomas, nerve sheath tumors that can originate of these nerves. We also have an approximation of the meninges, so meningeal tumors, such as a meningioma, can arise here. So that would be one of our major culprits of a potential jugular foramen mass would be a meningioma. And then we also have the paraganglia that sit here. So paragangliomas can originate in the jugular foramen as well. So if you want to think about three basic primary tumors, the big three that originate in the jugular foramen, we're thinking about schwannomas, meningiomas, and paragangliomas. So whenever we're dealing with a mass that's centered in the jugular foramen, as I've hinted at before, it typically originates from one of the anatomic constituents of the jugular foramen. Now, it can also extend outward, it can invade adjacent structures, and this is an area where CT and MRI are complementary for trying to tease some of this out. So we can look at the bone changes on the CT and the signal characteristics on MRI and have a really good idea if we're dealing with a schwannoma, a meningioma, or a paraganglioma, because all three of them will have very different bone changes and all three of them will have very different signal intensity. So let's start off by talking about jugular foramen schwannomas. These are benign nerve sheath tumors, and when they originate in the jugular foramen, it can be of cranial nerve 9, 10, or 11 origin. Again, those are the cranial nerves that live here. What do we look for on bone CT? We look for sharp margins. They're often almost surgical in appearance or cookie cutter type appearance, often with a very thin sclerotic margin, expansile characteristic. This is because schwannomas grow very, very slowly. The bone sort of remodels around them as they slowly grow over time. They don't grow so fast that they're erosive and invasive of bone, but rather the bone has time to play catch up and remodel itself around it. We can also use the MRI signal characteristics. Schwannomas lack high-velocity flow voids that we see with paragangliomas. We'll talk more about that in a couple moments. They tend to be very avidly enhancing. They may contain intramural cysts, particularly as they get larger, they can have more cystic areas. And because they originate along the nerve of origin, okay, they grow sort of eccentric to that nerve of origin, as they grow, they're going to track along the trajectory of that nerve. So their growth vector is along the expected trajectory of the nerve. So here's an example of a jugular foramen schwannoma. On the left, we have our axial non-contrast bone protocol CT image, and we can see this right jugular foramen is expanded, it's enlarged, has a thin sclerotic margin. Honestly, looks relatively unremarkable. If you had just this non-contrast CT, it'd be very easy to walk past this. Same patient, here's an axial T2 fat-saturated image. We can see there's a round mass centered in the jugular foramen. It's fairly homogeneous in terms of its signal intensity. It's approximately iso-intense to the cerebellum. And when we give contrast, this enhances avidly. So this is a great look for a jugular foramen schwannoma. Again, we use the MR signal characteristics and the CT bone changes to come to that decision. This is the trajectory of the expected growth pattern of a jugular foramen schwannoma. As you can see, it's growing along the expected trajectory of that nerve. It exits the brainstem, it comes down, exits down the jugular foramen. This is growing sort of in a sausage-shaped manner along the course of that nerve. And we can also get the sense how this is sort of slowly remodeling the bone. It's not chewing it up, but it's slowly expanding it out. That's the same appearance that we're now seeing on this coronal non-contrast CT image. Thin sclerotic margin, but it's expansile. And then when we give contrast, it enhances avidly. You can see these little areas of sort of intramural cystic change, particularly notable whenever schwannomas get larger. All right, our next primary tumor is going to be our jugular foramen meningioma. This is a benign tumor that arises from arachnoid cap cells. On CT, what we look for are permeative sclerotic bone changes, sometimes, but not always, associated with hyperostosis. On MRI, these are going to be avidly enhancing masses. If you look carefully, particularly using your multiplanar reconstructions or multiplanar imaging, you'll see dural tails of enhancement. These lack the high-velocity flow voids that we see with paragangliomas, and unlike schwannomas that extend along the trajectory, that normal course of the nerve, these extend out in all directions. They have a centrifugal spread pattern. So here we can see this jugular foramen meningioma. It's got this permeative sclerotic appearance to the bone, and it's spreading out in all directions. Here's an example of a jugular foramen meningioma on imaging. On our axial ADC map, we can see that it's relatively dark because this is a cellular tumor. On our coronal T1 post-contrast image with fat saturation, we see an avidly enhancing mass. If you look carefully, you can see some dural tails of enhancement, and this is sort of permeating through the bone, the occipital bone here. And then our T2 weighted image, we can see that it's sort of iso-intense, maybe a little bit on the darkish side, because again, this is a cellular tumor. And again, look for that dural tail of enhancement on our post-contrast imaging. You may have to look in multiple planes to be able to see that well. Here's an example of the bone changes that are associated with the jugular foramen meningioma. On our axial non-contrast bone CT image, we take a look at the jugular foramen on the right. On very cursory glance, it may not look may look relatively normal, but if you look at it, it has sort of a sclerotic, permeated appearance, and you can see there's a little bit of hyperostosis where the arrow is denoting. And this is really notable when you compare it to the contralateral side. You can see just how sharply defined thin sclerotic margin the normal appearance of the jugular foramen is. Contrast that to the permeative sclerotic bone changes seen on the affected side. And then on the T1 post-contrast fat-saturated axial image on the right, it actually is a little hard to see the mass because it's spreading in a centrifugal pattern and it's infiltrating and extending sort of in a transosseous distribution everywhere. So the whole mass is really encompassing this entire area. We can see sort of this dural tail of enhancement that's sort of extending along it. It's maybe not most notable on this reconstruction, but if you look on the other planes, you may see more of sort of that dural thickening, but here we can at least see it protruding out along the dural margin. And again, this has that centrifugal spread pattern. It's spreading out in all directions as it grows. And then our last primary tumor of the jugular foramen is going to be our jugular paraganglioma. These are benign tumors of chemoreceptor cells that originate in that jugular foramen. On CT, what we look for are permeative destructive bone changes. So it's going to chew up the bone as it permeates through it. On MRI, we look for that classic salt and pepper appearance. The salt isn't really sodium or anything in it. It's actually referring to the speckly T1 bright appearance that we sometimes, but not always, see with paragangliomas. Those T1 bright foci are due to blood products. And then our pepper, typically best seen on T2 weighted imaging, but we certainly can see it on the T1 post-contrast sequences as well. That corresponds with the high velocity flow voids. So the dark things are the pepper, the bright things are the salt. Kind of cute terminology, but it's very characteristic of paragangliomas within the head and neck. These are incredibly vascular tumors, so they enhance really, really avidly. And as this diagram nicely shows, they have a characteristic superolateral vector of spread. So they originate in the jugular foramen, but they extend superiorly and laterally into the floor of the middle ear. So that superolateral vector of spread, very characteristic of a jugular paraganglioma. So here's an example of a jugular paraganglioma comparing coronal images. Here on the left, we have a coronal non-contrast bone image, and we can see this permeative destructive mass centered at the jugular foramen, and it has a superolateral vector of spread pacifying the middle ear with tumor. Same patient, we can see this avidly enhancing mass centered in the jugular foramen with that superlateral vector of spread into the middle ear. And we can see some of those high velocity flow voids within it, the so-called pepper within this superlaterally spreading jugular paraganglioma. Sometimes when they spread into the middle ear like this, they're referred to as a jugulotympanicum paraganglioma. Here's another patient with a jugular paraganglioma. You can see the image on the left. We have our axial. This is a contrast-enhanced CT, but shown in bone algorithm reconstruction. We can see that there's a mass centered in the jugular foramen. But look at the bone. This permeative destructive change is sort of smudgy and irregular, where the bone has been chewed up by this permeative destructive change. Here's an axial T1 pre-contrast image. We know it's pre-contrast because the sinonasal mucosa is dark. That's the best test to know whether or not you've got contrast on board. If it's dark on a T1 sequence, we know it's a pre-contrast. And here we can see just sort of this speckly T1 signal hyperintense mass. That's the so-called SALT that you may see in a paraganglioma. We don't always see that T1 bright signal within paragangliomas. When you do see it, that's the SALT we're referring to. This is an avidly enhancing mass, and you can see all these squiggly little high-velocity flow voids on the T1 pre-contrast and T1 post-contrast. That's the so-called pepper, the dark stuff of those high-velocity flow voids. So again, permeative destructive bone changes, speckly T1 bright signal SALT, and those high-velocity flow voids, the pepper of a jugular paraganglioma. Now that was our discussion of primary jugular foramen masses. We can also encounter secondary jugular foramen masses. I would say they're less commonly seen. And these are masses that are centered outside of but grow into the jugular foramen. Far and away, the thing that we see most commonly is going to be metastatic disease to the skull base. And sort of within that discussion, you might also consider myeloma or plasmacytoma as well. Sometimes skull-based chondrosarcomas can grow their way into the jugular foramen. And then you may see Langerhans cell histiocytosis as well, involving the jugular foramen at the skull base, much less commonly. But really, metastases will be far and away the most common secondary jugular foramen mass that you encounter. This is an example of jugular foramen metastasis. Here we can see on our axial contrast-enhanced CT and bone algorithm reconstruction this punched-out lesion along the occipital condyle, but we've lost that cortical margin along the jugular foramen, so this is actually growing into the jugular foramen. We're not going to call this a schwannoma, even though it is a fairly punched-out appearance, just because of the fact that this is not centered in the jugular foramen, but rather this is centered in the occipital bone, and it's growing into the jugular foramen. On the contrasted CT, we can see this thing enhances very, very avidly on both the axial and the coronal post-contrast imaging, and this was renal cell carcinoma with skull-based metastasis. So, to summarize the bone changes that we should be thinking about with jugular foramen masses. All right, these are going to be the big three primary. So first of all, image on the left, we have our expansile, sort of benign appearing thin sclerotic margins to it. This is that benign expansion or cookie cutter appearance of a jugular foramen schwannoma. The image in the middle, we've got our permeative sclerotic bone changes with a little bit of hyperostosis. This is going to be characteristic of meningioma. And then the image on the right, we've got our permeative destructive bone changes about the jugular foramen. This is characteristic of a jugular foramen paraganglioma. And then think about the vector of spread. If the mass is extending along the expected course of the cranial nerves, dropping down through the jugular foramen, that's a really good look for this being a schwannoma. If it has that centrifugal spread pattern in which it's going north and south and east and west and every direction, that's a good look for a meningioma. And if it has that superlateral vector of spread into the middle ear, that's a great look for a jugular foramen paraganglioma. So circling back on this initial index case, again, a patient with headache, tinnitus, and hoarseness, we see that there's a mass centered in the right jugular foramen, has permeative destructive bone changes. It's very intrinsically T1 bright. It's sort of the SALT look. We can see that there are high velocity flow voids within it. And this is going to be a jugular paraganglioma. So in summary, your differential diagnosis for primary jugular foramen masses is actually very short. The big three are going to be schwannomas, meningiomas, and paragangliomas. Because metastatic disease is so common, this is a really important thing to also be thinking about. It can secondarily involve the jugular foramen as it grows there. Much less commonly does it just sort of set up perfectly in the middle of the jugular foramen. But again, because of hematogenic spread of metastatic disease, that is possible, but usually what we see is something that's more adjacent to it. And again, wanting to stress, CT and MRI are quite complementary. Use those bone changes on the CT and use the signal characteristics on MRI to very accurately narrow down your differential diagnosis. You're not just drumming up more business recommending that we get a CT or get an MRI if the other has been done. These things actually work very hand in hand to help come up with the right answer. So with that, thank you for your attention, and continue to tune in to this channel where I'll be putting up more tutorials and lectures.